Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to pick up and fill out a program evaluation. And if you could, please give us any ideas you might have in regards to future topics or future speakers. I was telling Dr. Kitchell that this topic was actually suggested from one of the program evaluations. Today, I have the pleasure of reintroducing Dr. Mike Kitchell. Dr. Kitchell, as a lot of you know, is not only a board-certified neurologist and director of the inpatient Mary Greeley Rehab Unit, but he's also an expert in matters pertaining to healthcare financing and reimbursement, and in fact has testified in Washington, D.C., and he has kindly accepted our invitation today to update us on a fluid topic. His topic or the title of his talk is Medicaid, an Uncertain Future, and please join me in welcoming Dr. Kitchell.
Thanks. Hopefully the microphones are on and I'm ready to go here. I'm going to be going over a lot of facts and figures, and I'll try to be as objective as I can be, but sometimes I do get a little bit of an advocate, and so you'll probably see some of that coming through too. So Medicaid occurred shortly after Medicare did in 1965, and over the years it's actually been supported pretty well by public surveys. In fact, 70% of the public supports the funding of Medicaid. My concern is, what about that other 30% who doesn't support the funding of Medicaid? But we'll talk about that a little bit later. Medicaid covers 4 different categories: the children and mothers, not all mothers, but most mothers, senior citizens who don't have enough money. It's not just Medicare. A lot of people have dual eligibility for Medicare and Medicaid. Obviously, the disabled are on Medicaid. And then, as you probably know, before Obamacare, just because you were poor did not mean that you got Medicaid. It was not until Obamacare that the low-income Americans actually were all covered, or were all potentially covered by Medicaid. And even though you know that some children are covered by Medicaid, most of the money that is spent in Medicaid is actually for the disabled patients and patients in nursing homes. Those are about, like I say, 70% of the dollars spent in Medicaid go to take care of those sicker people. Now, Medicaid in Iowa is a pretty large part of the budget, the state budget. The proportion that comes from the state of Iowa is about $1.7 billion, and next year the state budget is going to be $1.8 billion for the Medicaid budget. But the total dollars actually come about 2/3 by federal funding. And the latest expansion of Medicaid, which, as you know, occurred because of Obamacare, that actually started out as 100% funded by the federal government, and it's going to taper down to 90% over the next few years. To this year, 95% of the funding of Medicaid expansion patients, that's 150,000 patients, that is coming from the federal funds. So the total number of Iowans who are covered by Medicaid is now about 600,000 people. And it's estimated that about 77 million Americans, or about 22% of the population, are covered now by Medicaid. And that is estimated to grow by 2026 to 86 million Americans. And if you didn't know it, the largest insurer in this country is not Medicare, it's Medicaid. Only about 15 to 16% of the population is covered by Medicare. And so 22% of the population is covered by Medicaid. So it's the largest source of insurance, whether it's private or public. It's the largest source of health coverage in this country. And in Iowa, it's about 21% of the population right now is covered by Medicaid. So the breakdown of who is covered, it's involving 6 million elderly. That's not all of the Medicare population, but 11 million patients actually have dual Medicare and Medicaid coverage. And 64% of nursing home residents are covered by Medicaid. That's what I said. That's a large portion of the dollars spent by Medicaid. Now, parents and childless adults, 27 million Americans, and blind or disabled, about 9 million. There are 34 million children that are covered by Medicaid, and about 6 million who are in the program called CHIP, the Child Health Insurance Program. And so between the two of those, about 37 to 40% of all American children are covered by either Medicaid or the CHIP program. As you may have heard, too, our U.S. Congress has not met the deadline for funding of the CHIP program, and so some of the states are running out of money right now for the CHIP program. There's still optimism that the Congress will actually fund the CHIP program, but it's still not done yet, and it was due October 1st. About 40 to 46%, depending upon which source you read, of all pregnancies are Medicaid. I thought that was an amazing statistic. Almost half the births in this country are from parents that are mothers that are covered by Medicaid. So as I was saying before Obamacare, not all low-income Americans were eligible. It was only children, pregnant women, parents, elderly, and disabled were able to get coverage before Obamacare. And adults who were not disabled or parents with or people without children did not get Medicaid, even if they were very low-income Americans. CHIP, though, actually was able to give insurance to the near poor or the middle-income families, and that's why I say the CHIP program has been a very important source of coverage for those children in the United States. So the spending, the latest numbers aren't in for 2016 yet, but the spending for Medicaid was $545 billion. And as I said, in Iowa, about 2/3 of the funding comes from the federal government. Overall, some states, though, have less percentage coming from the federal government. For example, Massachusetts is about 50-50. So overall, about 57% of the funding for Medicaid comes from the federal government. And as I said, the expansion Medicaid population, the first couple of years it was 100% funded. This year it's 95% funded, and it'll go down to 90% funded from the federal government. And the per capita spending per patient, it's about $7,800 per year, but that really varies from state to state. Some states it's only about $5,000 per patient. In some states it's about $10,000 per patient. So again, what is the total dollar figure for the federal budget? 9% of our federal budget goes to Medicaid. In the state of Iowa, it's $1.8 billion out of about a $7 billion total. So again, it's a pretty significant part of the state budget. So these statistics are where do those $545 billion for Medicare go? Managed care plans are actually covering about 70 to 74% of the patients in Medicaid, but some of these percentages actually are also coming from managed care plans. But basically, this is just a way to show you where the dollars go. And about 13% goes to hospital inpatients. About 10% goes to physicians, but that includes the outpatient scans like MRI scans, CAT scans, procedures, and so on. Other acute care services, 10%. I was surprised that the prescription drugs are only 2%, but that doesn't include the chemotherapy costs. Those chemotherapy costs are in the physician outpatient services for the most part. Some of those are in the hospital inpatient too. So don't get the idea that prescription drugs are less than 2%. They're definitely higher than that. It's just hard to sort that out. And as I said earlier, a lot of the dollars in Medicaid go to home health and long care facilities. That's 29% here. But if you take that managed care part out, a lot of, because some of the managed care plans are paying for those nursing home care too. So again, at least a third of the dollars in Medicaid are going to the nursing homes or home health services. Medicare payments for some of those dual eligible take about 4%. At hospitals that have a disproportionate share of low income patients, and there are some hospitals in Iowa who depend upon this, that's about 4% of the Medicaid dollars go to them. So as I said, about 70% of the spending is for people who are in nursing homes or who are disabled. If you recall, the Emeritus company, the managed care organization, they pulled out of Iowa. It was basically because they had a larger share of those sicker patients, and so they were spending a lot of money on these disabled and nursing home patients. And so they were really pulling out because of that issue, that the sicker patients, they got saddled with them. And then, as you know, Emeritus wanted to give them to the other two companies. But one of the companies, Amerigroup, has decided, nope, we don't want those sicker patients. So I couldn't put this into my slides because it was just announced yesterday that the state of Iowa has come back and is going to cover 10,000 of those sick and disabled people because nobody wants to touch them. Again, of the billions of dollars spent on long-term care, some of those dollars that go to home health services keep people out of nursing homes, which are more expensive than if we keep these people at home. So there is a good reason why we spend some money on home health services. It's not only what the patients want, it's cheaper. So I'm going to talk a little bit about the Obamacare expansion. As you recall, not every state took advantage of that 100% federal funding. There were 19 states who refused to expand Medicaid, even with that 100% funding. And some politicians complain that the Affordable Care Act has benefited the poor but able Americans. They are angry because Obamacare is paying more for those able-bodied, low-income Americans who don't really care to work, while they're paying less for the traditional Medicaid population that are disabled, sickly, and elderly in nursing homes. So if you detect a little bit of disdain for some politicians, that's probably accurate here today. So there are some political proposals that could affect Medicaid's future. There are some laws, and the Trump administration has recommended that only able-bodied Americans are not eligible for Medicaid, despite the fact some of these able-bodied Americans are taking care of other disabled Americans in their home. This is a hot issue right now as to whether those low-income, able-bodied Americans should deserve those Medicaid funds. One of the other issues is the block grants. And does everybody know what a block grant is? Block grants are basically, here's your $10 billion, use it wisely. And so some states would get a fixed or a capped amount of money for their Medicaid population, and usually it's less than what the states have been getting. So that is a tactic to try to hold a lid over the costs of the Medicaid program, those block grants or caps. And so some of these political proposals actually will lead to a 26% reduction in federal funding. And so 15 million Americans would lose coverage if those caps actually occurred. That's part of that Medicaid expansion issue too. But again, a lot of Americans would lose coverage with those block grants or caps. The American Medical Association has always been strongly opposed to these block grants or these caps on Medicaid payments. Now, a few years ago, there was a term called Medicaid modernization, and it was designed allegedly to improve care and efficient use of resources. So that modernization of Medicaid in Iowa led to a strategy of having 3 private managed care organizations take over the care of these Medicaid patients. So in the last 20 months, we know a little bit more of what's happening now, that AmeriHealth has dropped out, and AmeriGroup says that they are unable to take those patients from the AmeriHealth, and so there are about 185,000 Iowans who are probably going to sign up for United Healthcare, minus that 10,000 number that the state of Iowa will apparently be covering. Now, despite the difficulty in paying for all of these patients, the state of Iowa Medicaid director has promised a 3.3% raise for these 2 MCOs for 2018. But that's going to be hard to achieve because the budget in Iowa is not in really good shape. Right now, it looks as though we're going to have a big budget shortfall. There's also a legislative committee, and Lisa Heddens is our representative from Ames, and who is on that legislative oversight committee. Since the beginning of the MCOs in April 2016, there's a 10-member legislative health policy oversight committee that was supposed to be meeting twice a year, but I'm sure Lisa would say that it wasn't her fault they weren't meeting this year, but they finally had a meeting on November 8th, and I didn't see any reports on their website as of today. Obviously, there was a lot of controversy regarding that. Governor Reynolds, though, has announced that a 3rd MCO will be invited to participate, so to take the place of AmeriHealth by next summer. So maybe not all of you know this, but the payment issues for physicians have really been impacted significantly by what the Iowa legislature did just on July 1st. With a very short notice, the Iowa legislature voted to cut physician fees for primary care physicians by 33% for their E&M codes, that's evaluation and management codes. So those primary care physicians at McFarland Clinic lost a total of about $1 million. We had a physician at McFarland Clinic who sees a large number of Medicaid patients. She had a pay cut of $85,000 because of what the state legislature did on July 1st by cutting those fees by 1/3. So you may ask, okay, well, how is that going to help the budget for Medicaid? Well, as I showed you before, 10% of the dollars in Medicaid go to physicians. But if you look at the primary care physicians, it's only about 1/3 of the dollars actually go to those primary care physicians, the specialists, the proceduralists, the MRI scans, the chemotherapy dollars. So again, primary care takes about 3% of the Medicaid dollars to do their work, but they were cut by 1/3. That also affected the specialists, though, because as of July 1st, I was affected because as a specialist, I can no longer charge a consultation code. In fact, the 3 managed care organizations also were denying specialists who were the second person to see that patient. We were not allowed to charge even an initial visit. We were only allowed to charge, quote, subsequent visits, which is a miscoding and, of course, much lower payment. We've been fighting that, but I haven't had success yet in getting them to understand that if a consultant is seeing a patient, it's not a subsequent visit. It's not a cheap visit. If there's a very sick patient, obviously, those consultants are doing a lot of work on those patients. But for the last 6 years, the Obamacare rules actually increased the payments for primary care physicians. And now that the primary care physicians were cut by 1/3, now they are getting the same amount as E&M codes for specialists. So we, again, have been getting about 2/3 as much for our E&M codes as Medicare pays us for those E&M codes. So it's not just the physicians, though, that have been upset with the MCOs and the way things have been going. I was at the Iowa Hospital Association meeting about 6 weeks ago, and there was one hospital after another complaining about the MCOs, that they were denying multiple claims, including a patient who had a cardiac arrest who needed a defibrillator. The MCOs denied the claim for that care of those patients. It was really amazing how the MCOs all apologized and said they were going to try to do better, and they've been doing this for 20 months. But and that may be one of the reasons Unity Point has given notice. The Unity Point hospitals around the state are going to drop AmeriGroup's contract in 2018. So that might affect 54,000 Iowans. I don't know the latest negotiations, though, regarding that. So it could happen that they will sign with AmeriGroup if AmeriGroup satisfies the concerns of Unity Point. There was a occurrence recently. The state of Iowa actually asked the federal government for a waiver to pay hospitals less. There is a retrospective eligibility that the social workers know about. If a patient comes into the hospital and doesn't have insurance, they're going to start running up the bills right away. But if that patient is eligible for Medicaid, they could go back and have a retrospective payment. The hospital could have a retrospective payment for that Medicaid patient. But the state of Iowa acted to try to eliminate that retrospective eligibility. So that is going to cost Iowa's hospitals, might affect some doctors as well, for about $36 million. So I don't think the Iowa hospitals are happy with what happened there either. Now, the national scene, as I said, is at least as chaotic as what we've had here in Iowa. The U.S. Senate had in their budget bill, which was passed on October 18th of this year, they outlined a $473 billion cut for Medicare and a $1.1 trillion cut for Medicaid in the next 10 years or so. And of course, they would eliminate the ACA mandate so that insurance would be more expensive for the people who were in the ACA program. and there would be an estimated 15 million people who would be uninsured. Now, the latest tax reform bill, which I think you're seeing more publicity about because of that Senate bill, which will again reduce taxes for some of the businesses and corporations, that's going to cause an immediate budgetary cut called pay-go. In other words, the rules in Congress now, if you cut the budget, you have to cut everything. Well, not everything. There are a few things that are exempt. But it would cut Medicare by 4%. So as of 2018, if this tax reform bill passes, the Congressional Budget Office has said that the Medicare provider payments to hospitals and physicians will immediately be cut 4% per year. The total amount for that Congressional Budget Office estimate was $400 billion of cuts to Medicare. And of course, we know that the cuts would be greater than that for Medicaid, because obviously Medicaid expansion would be eliminated and the mandate would be eliminated. There are going to be more block grants proposed in Congress. We'll see what the results of all of those legislative attempts, again, to change Medicaid into a capped program or limited funds for the Medicaid population. So part of this Medicaid modernization was that states should come up with their own innovative ways of trying to take care of their population of patients at a lower cost. In other words, not have a big federal bureaucracy tell people in the states how to manage their Medicaid populations. Let's come up with some innovative solutions. And so the solution in Iowa was to have these managed care organizations. And do any of you think that there's much of a difference between the managed care organization and an HMO? If anybody can tell me the difference, please let me know. So I don't really think that managed care organizations are all that modern topic or a modern way of taking care of patients. They claim that they give better care coordination. I don't know if any of you have seen how wonderfully well they do care coordination. We at McFarland Clinic believe that we do a very good job of coordinating care, and we would rather have an accountable care organization to help us manage the care. In fact, Governor Branstad was interested in having accountable care organizations in Iowa. In fact, the Iowa Medicaid Enterprise actually applied and got a SIM grant. That's a state innovation grant. And it was only 2 months after Branstad had received that grant, which was basically going to use accountable care organizations to take over the care of the Medicaid population, that Governor Branstad suddenly decided to go with the managed care organizations. And you may say, okay, well, why is this that all of these things are happening? Some politicians actually claim that insurance is not necessary for better health, and I've heard many politicians say how terrible an insurance product Medicaid is, and that's why there's been this real switch from state-run Medicaid programs to the managed care or private insurance companies. In fact, it's about 74% of Medicaid populations in states are now covered by private insurance. Now, how many of you here believe that insurance isn't necessary for better health, that having insurance or not having insurance doesn't make much difference in your outcome? I don't see any hands raised here. So here's the evidence. Multiple studies have shown that patients who have Medicaid coverage, they have a lower mortality and that happens almost immediately. Medicaid increased preventive care. It increased the medication usage because people couldn't afford medication. It increased the diagnosis and treatment of chronic diseases, and we know that chronic disease can be very expensive if it's not treated over the years. It improves the outcomes for patients with depression, and people with self-reporting of their health have a much greater improvement in their health that they report with Medicaid. And then, of course, it's pretty obvious it avoids those spending out-of-pocket costs, and many bankruptcies have been related to not having insurance. Now, I'm not going to spend too much time on this, but the Democratic Senator, State Senator McCoy and Representative Forbes have sponsored a bill to end the MCOs, bring back the state-run program, and to let those people who are getting really expensive insurance on the Obamacare exchange, which is sometimes $33,000 for a family of four for their health insurance on the Obamacare exchange for 2018. These two, these senator and representative, want to let those patients buy into Medicaid instead of spending $33,000 for a policy from Medica, which is the Obamacare product now. So as I said, about 74% of Medicaid patients are covered by private insurers, and there is no evidence that private insurance or public insurance is better for the outcome of the patients. And I think that's pretty obvious because some states, their Medicaid program really was pretty poorly run. If you read the paper this morning, the Medicaid director in Iowa says that our Medicaid program is run really well. So there is no evidence that having private insurance or public insurance that patients do better. But as I said, there's a good reason that people should have insurance. Now, there is one state, though, and that's Connecticut, that dropped their managed care organizations and successfully went back to a state-run insurance at a lower cost. And then Arkansas was granted a federal waiver during the Obama administration to have Medicaid expansion. And so when Arkansas expanded their Medicaid population, they actually gave them private insurance for 100% to 138% of the poverty level. And so they were using private insurance instead of the state-run Medicaid program, except it cost 24% more. So anyway, trying to finish up here before I run out of time. The opportunities that are there for giving better care are there for whether it's Medicaid, Medicare, or the private insurance companies. As I've said before here, we believe at McFarland Clinic that accountable care organizations being accountable for cost and for quality is the way that we prefer to practice. Not having a third-party managed care company tell us what we should do or what we should not do, or have all these authorization or pre-authorization requirements as a third party. And then every hospital in Iowa will tell you that they do not like all of these claims denials and all of the hassles that they have appealing those claims denials. So what we want to do to have better care, whether it's in the Medicaid program or in the private commercial insurance, we want to improve care coordination, which gives better outcomes. We want to reduce the substance abuse and all those complications. Remember, substance abuse is the leading cause of death in the 20 to 30-year-old age population now. And then we want to make sure we improve mental health, because we know when patients have some mental health issues, they generally have more physical problems as well. And then, just as I said earlier, if we can keep people in their home and give them some services so they don't have to go into a nursing home, that's going to save money for everybody. And it's going to make people happier because they don't have to live in a nursing home. And then the social determinants of health, which are poverty, low education, lack of social support, lack of a ride to go to the doctor, those social determinants of health can actually affect the spending in healthcare, spending on healthcare by about 20 to 30%. That's felt by some economists to be equal to the amount of influence that we as physicians or healthcare providers have on the health outcomes of our patients. So there's a lot more interest and work done to address those social determinants of health. Other countries around the world spend a lot more money on social services than the United States does, but they spend much less on medical care. So maybe we ought to take a little bit of a lesson from those other countries, that if you have better social support, you won't have as high amount of medical costs. That's what our ACO is doing with what we call our Population Health Department. Our Population Health Department has the task of getting people in for their care, making sure they remind them of what they need to do, and then taking care to see what those people need so they don't have to run to the emergency department every time they have a little problem. So again, those type of things can reduce costs, can improve care, both for the Medicaid population and for the commercial insurance as well. Then, as I said earlier, there's a huge variation from state to state with how much is spent per patient. Some states are $5,000 a year, other states are about $13,000 in the most expensive states. Now, as I said, for Advocacy, the American Hospital Association, the Iowa Hospital Association, the American Medical Association, the Iowa Medical Society have all taken strong stands against Medicaid cuts or increases in the uninsured. So I hope all of you will take advantage of that ability to be an advocate. And before I end, could someone bring a microphone? Lisa Heddens is our representative, and she was kind enough to attend the talk today. And Lisa's right down here. And I would like her to correct anything that I said or add anything. Lisa is the ranking Democrat in the House for the Health Care Committee.
Health and Human Services budget, yeah, that covers Department of Human Services, Public Health, Aging, Veterans Affairs, and the Iowa Veterans Home. I guess just a couple things that I'd want to talk about is, as Dr. Kitchell referenced, AmeriHealth pulled out of the serving populations in Iowa. Families had the option to choose either AmeriGroup or United. They had to do that by November 16th. Those that did choose AmeriGroup by November 16th have now been told that, nope, you're not going to be with AmeriGroup, you're now going to be under the state, and that's where that 10,000 plus comes from, under that fee-for-service program. So that's how that's going to be run with those folks. Everyone else will be with United. I'm very acutely aware of this. I have a son with an intellectual disability, and I got my letter from the state on the 16th, so I didn't even get an option to choose, as with a number of other families. Secondly, there is going to be potentially a third managed care company coming in. It was originally supposed to be in July of 2018, and the governor pushed that back to 2019. So that's the newest development out there. And then lastly, I just want to say that a number of home health organizations have contacted me in regards to, they were signed up with AmeriGroup for this 10,000 people to provide home health services. Since the state is taking them over, the state pays a less rate than what AmeriGroup was going to pay. So several of these home health agencies may be dropping all those clients altogether because they just can't afford to service them. So that's the challenge that we're facing right now, and that may have a greater impact on hospitals because they're not getting that in-home services that Dr. Kitchell referenced. So a lot of things are still in flux. We don't know where things are going to end up in the state. And lastly, the CHIP program, or Hawkeye program, the state has money till about the end of February to cover those children. And that's about 50,000 kids that could be looking at losing health care coverage. So that's another significant impact facing the state.
Thanks, Lisa. And I presume there are going to be some more questions.
Mike, as you know, the only developed country in the world that does not have universal health care is the United States. And I think we're the only one that runs health care as a for-profit business, as opposed to a non-profit service like the police and the fire people. Do you have any idea what the profit is in Medicaid in Iowa?
No, I don't think I could estimate that. And Lisa, you know, the managed care organizations claim that they are losing at least $100 million a year, and that's basically been the report of almost every state. For example, Kansas had a huge report of losses by the managed care organizations the first year that they came into being in Kansas. So this is kind of a rerun of what's happened in other states. But you know, United Healthcare is a Wall Street company. You can probably look at their profit line and see what their I've heard that people are recommending that you buy health insurance companies because they're very profitable.
Mike, I just want to add that Iowa's new Medicaid director is the former Medicaid of Kansas. And so the challenges that Kansas faced, we could potentially be facing here in Iowa as well.
Lou.
A question for Lisa. These alleged losses, actually, are they audited by any state organization to verify that they're experiencing these losses in the MCOs?
They're a private entity, so we really have no option to go in and do that. That's been part of our discussion, is that they are receiving state dollars, but they are a private entity.
At the risk of being glib, Medicare is always touted as being something that's running a debt anyway. I mean, isn't it possible on a federal level we'll just say, oh yeah, well, we're cutting Medicare and we'll just borrow, and it'll just go further and further in debt?
Yes, that's definitely not just a cynical view. I think that's a realistic view. It's been said, though, that hospitals around the country are only getting paid about 80% of their costs for Medicare patients, and hospitals are getting less than Medicare in most states for Medicaid patients. But the Medicare situation, remember, the critical access hospitals get Medicare costs, so whatever their costs are, they get about 1% more. Incidentally, Fort Dodge Trinity Regional Hospital was just announced as being part of a program, a pilot program, where Trinity Regional Hospital will now get the same as the critical access hospitals. They'll get a proportion of the costs, the actual costs that they're spending on Medicare patients. But again, I can assure you Mary Greeley is probably getting about 80% of their costs for the Medicare population, and I'm sure it's much less than that for the Medicaid population. Now, we don't have a huge Medicaid population here in Story County, but as I said, some of our physicians, for example, in Marshalltown, our pediatricians, they are 2/3 of their patients are Medicaid patients. So it's a huge part of their practice. Even our pediatricians here in Ames, 1/3 of their patients are Medicaid, and I think for our obstetricians, at least 1/3 of the obstetrics patients are Medicaid patients. So again, it's a fairly significant impact here. Okay, any other questions? If not, thanks for attending.